Good day to everybody. Thank you for joining us for the second session in our EEG trending webinar series. This is the intermediate session being presented by Marco Moreno. I'm Lori Kaufman and welcome. A few housekeeping notes. This session is being recorded and will be made available after the webinar. All attendees are muted and in listen-only mode, and attendee webcams are all turned off. We welcome any questions during the presentation. There's a question pane in your GoToWebinar control panel. Attendees can ask a question by entering it in that pane, and we will read those questions throughout the presentation. Asset education credits have been approved for those attending this session live. If you have an asset ID number and you want to get credit, please email that number along with your full name to workshops@cadwell.com and refer to this session. You do not need an asset ID number to obtain those credits. We will also be having some polls throughout the session that you're encouraged to answer some education questions. Thank you, and again, here's Marco. Thanks.
Thank you, Lori. Thanks to all of you for attending. I'm going to do my best to keep this on time. So I'll go ahead and get started. I will break frequently for questions. So if you have questions, please send them via the chat, and I will stop and take those questions. And Anita, who is also on, Anita, I don't know if you want to introduce yourself and say hello, but Anita will help me manage those questions. All right, so let me get started. This is the intermediate session. We went over the basic session last week. And so what you're going to see is a lot of the same stuff that we saw last time, but in a little bit more detail. And we'll add some other information like trend settings, a little bit deeper on the trend panels, and talk about modifying the trends. And one of the questions that came up last week was, how do you deal with artifacts? So we'll talk about dealing with artifacts. That's obviously the bane of any trending graph that doesn't give you the detail. So we of course have to get to the detail there. So we'll start with a review of what we covered last week, and I'll go through these rather quickly. So what is a trend? Well, as we described last week, a trend is basically a series of data points, and you plot those on a time base that gives you information about what's going on in a particular series of days or minutes or seconds. And really, it does not give you the minute detail. What we're looking at is a high-level overview of whatever it is we're assessing. In this case, we're looking at EEG. But looking at the trends, looking at these basic numbers, gives us an idea that there may be something going on. Doesn't tell us what's going on. So if we look at this particular trend, which I think everybody's familiar with, we know that something went on in April. We can see that in the green line. We know that it happened again, but with greater magnitude in July going into August. Now, we don't know the details. We don't know why it happened. We don't know exactly what happened. All we know is that the numbers increased, and we want to dig into more detail there to find out what the cause was, what happened, etc. So to apply that to EEG, how do we derive this information from our EEG? Well, largely the same way we would with any numerical sequence. We're going to break it into segments. We call these epochs. And then we're going to analyze them for some characteristic, be it amplitude, frequency, power, and we're going to plot that on a graph. In this case, if you look at the diagram at the bottom, assume that's the EEG. We've got 4 epochs there. We're measuring the area under the curve, so we're going to plot a bar graph of that information. Now, that could easily be a line graph as well. We chose to do a bar graph. But so when we look at the raw EEG, we're looking at amplitude, frequency, symmetry. Are things lateralized? Are they periodic? What is the phase? Are they in phase or out of phase? What kind of morphology things have? And we can see most of that when we look at the trends, but we don't see really phase and morphology. And that's what I mean when I talk about we're not able to see the detail. So when we look at the trends, we can see, we can get a good representation of amplitude. In some trends, we get a good representation of frequency. If we lay them out correctly, we have symmetry, and we have an idea of the periodicity. So in the trends that we'll be looking at, the x-axis is always going to be time. Our y-axis may be amplitude, power, frequency, ratio, or percentage. And our z-axis, which we only have a z-axis in the spectrogram, our z-axis is going to be a color scale, where a lot of activity is red and minimal activity is blue. So we'll start with the amplitude-based trends. And the amplitude-based trends include amplitude integrated EEG, the envelope asymmetry, and suppression ratio. And then we'll talk a little bit about the frequency-derived trends. I'll move through this rather quickly: the band power, power ratio, spectrograms, and the spectral entropy. Again, if you don't recall anything from this presentation, the one thing I want you to remember is what the purpose of trending is, and that is to identify areas of interest in the EEG. Typically, these are changes in the trend that we're trying to identify, and those changes draw our attention to the raw EEG. Trends don't detect seizures. I may slip up and say that a trend shows us a seizure, but really what it's doing is it's showing us a change in the record. And the clinician uses his or her own clinical judgment and expertise to go back to the raw EEG and make the determination of whether that's a seizure or not. So that's critically important for you to remember. Even if I slip up and I say it wrong, we're really just identifying changes in the EEG. So first quiz. So Lori, if you can put up the first poll, we're going to have everybody take a quick quiz. It's pretty early to start quizzing you on these things, but here's our first quiz. And the question is, trends identify blank in the raw EEG, in the EEG. So the first question, the first answer, I'm sorry, is burst suppression. And of course, trends really don't identify burst suppression. The trends may show a specific pattern. They may show data points that lead you to that conclusion based on your expertise, but they're not going to flag something as burst suppression. Similarly with seizures, again, we just talked about the fact that the reader uses their own clinical experience to identify seizures after examining the raw EEG. We don't get any information on morphology or phase. So 14 and 6 hertz positive spikes is not a good answer. So the correct answer is simply that trends identify changes in the EEG. So Lori, please go ahead and close the poll. So it's just changes in the EEG is all that we're able to see from trends. And again, the purpose is to draw our attention to the raw EEG. Raw EEG is the gold standard. It's really what we want to focus on. So let's talk about the individual trend analyzers, and we're going to start with the amplitude-based ones like the envelope trend. Now, we saw this diagram a little bit earlier where we're just taking the total power from each of these individual epochs and stacking them next to each other. One of the differences from this with the envelope trend is that with the envelope trend, we take a sliding median. So we're going to do the median of 1 and 2 and 3. Then we're going to do the median of 2 and 3 and 4, and all the way on up. And we just have a continuous sliding median of the data that's coming in. What that does with the envelope trend is it tends to help us even out artifact. So if you look at the data of let's say a daily temperature or something like that, you'll see it bounces up and down quite a bit during that day. But if you spread that out over a week, you get a much more even appearance of your graph. So this is what we see when we look at the envelope in a normal adult who's awake. And you can see that if you look at the trend, well, you'll see a couple of things. Number one, of course, the x-axis is time, the y-axis is amplitude. And just a quick value judgment, it looks pretty symmetrical. This is the left side over the right side, and to see very symmetric activity. Some earlier higher peaks, some later higher peaks. Nothing really significant that stands out. If we place the cursor on one of those later high peaks, you can see that the patient's awake. Again, symmetrical EEG. If we look at the box in the upper right-hand corner, amplitude, the amplitude that we'd expect. Frequency, well, the envelope trend only gives us amplitude information. It does not give us frequency information. Symmetry, we can see it looks pretty symmetrical, left versus the right. And periodicity or variability, we can see there's some variability in what we're looking at. If we look at the same person in sleep, again, this is the exact same trend. I just have my cursor placed a little bit earlier in that trend. And left over right, you can see what we have our cursor on is showing us stage 1 sleep, where we see sleep spindle or stage 2 sleep. So we see the sleep spindles, some slower activity. And again, our assumptions here are amplitude for symmetry, periodicity. We don't really see anything particularly about frequency. So this is generally pretty unremarkable. So what do we use the envelope trend for? Well, envelope trend is a good one for looking at seizures. In this case, we're looking at status epilepticus. And again, amplitude, symmetry, periodicity. So we can look at this and we can see, okay, we have several events going on here, and we can identify how many of those there are. We refer to the raw EEG to determine exactly what they are. And now we can say during this 4-hour period, we can count exactly how many seizures there are. If we go a little bit deeper, we can make certain adjustments to the envelope trend. The things that we might want to adjust are the inputs. If, for instance, I had something where I lost an electrode, let's say I lost FP1, or maybe I've got a tremendous amount of eye artifact, I can take FP1 out of the trend, and I can simply go to my settings, the little cogwheel that you see in the upper right-hand corner of that trend window, and I can make the changes to take FP1 out, or I could change the frequencies that I'm including in the envelope trend. Again, it's not a frequency trend, but we've got to set our window. I can adjust my epic count of my averages. This is the only trend where we actually adjust our epic count, because as I mentioned, it's a sliding median. So how many epics you count together may tend to smooth out your trend. Again, good if you're looking at events of short duration. May be bad if you're looking at short event duration. So let me restate that. So it's good to have a short epic count if you're looking at shorter events. If you're looking at longer events, you may want to average more epics. And this is in this particular case, you can see the top study is using an epic count of 1. Bottom one is an epic count of 50. For this particular study, not a significant amount of difference. You can see the settings are the same. As far as the amplitude goes, there's a slight difference in the bottom trend that's averaging 50 epics, and you can see it's maybe a little bit smoother, but just so slightly that it really is not too terribly significant. So this would be a case where I wouldn't be too worried about it. I just want to show the peak envelope in persist. Same sort of thing as I mentioned. This is actually the same data, and the difference is that persist does a line graph instead of the bar graph, and overlaps the two on top of each other. So again, amplitude, symmetry, periodicity are the things we're looking at here. We do not see frequency. So envelope asymmetry, largely the same calculations as envelope as far as taking the segments and generating those graphs, but what we're doing is now we are comparing left to the right. So if you look at the equation down there, you're doing a right versus right minus the left over the total. So this is good in that it gives us the ability to identify lateralization. And in this particular case, we've got normal EEG. And you'll see again, the x-axis is time, the y-axis is percent symmetry. And what we can tell from this is we've got a pretty symmetrical EEG, where we have things going from more right or more left tends to be artifact like chewing or something else, which you can see in this raw EEG. But overall, it's pretty symmetrical. When we have an abnormal study, what you'll see is a preponderance of the data to be right-sided or left-sided, as we see here. So as we go towards the top, you see it's positive. 59 is on the scale there, and that's a positive number, so it means it's on the right. Negative numbers mean it's more left-sided. And so you can see that whatever's going on here, it's more right-sided. So if we look at the raw data, again, I want to try and tie this back to the raw data. In fact, you can see a pretty stark abnormality there. Now, you don't need the trends to see this abnormality. What you need the trends for is to give you that high-level overview, to be able to see hours at a time, to be able to see the periodicity of how often this is occurring in this particular patient. So that's where the trends really help. The asymmetry just kind of gives us a good idea of whether it's lateralized or not. Things that we can adjust in the envelope asymmetry are primarily the same things that we adjust in the envelope trend. The difference here being if I select FP1 to F7, it's automatically going to add FP2 to F8. F7 to T3, it's automatically going to add F8 to T4. So you can adjust those and it will match them as you go. You can change your frequency range, you can change your color palette, etc. Amplitude integrated EEG. We talked about this. It is a measure of the high and low amplitudes in each epoch of the EEG, and we're going to filter it, rectify it, and put it on a semi-logarithmic scale so that it looks something like this. This is normal amplitude integrated EEG, and I say that again, we're looking at left over right, and in the last channel, a transverse montage. And for each of these trends, you're looking at a scale of 0 to 100, where the amount of space devoted to 0 to 10 is the same as the amount of space devoted to 10 to 100. So semi-logarithmic scale, it's linear from 0 to 10. But what we're going to assess from this is a normal amplitude integrated EEG because we see the variability in the EEG in the trend. And again, I'm making some assumptions, but this is what you will be able to determine from this is the amplitude is what we would expect. It's variable. The variability suggests that they're undergoing sleep-wake cycles, and the symmetry, the left compared to the right, looks pretty good. Again, we have no information with frequency here, but based on the amplitude, the symmetry, and the periodicity or variability, we think this is likely to be normal amplitude integrated EEG. Based on those same factors, we're going to determine that this is a burst suppression pattern. Because the amplitude is down at the bottom, you see most of the trend compared to this one, most of this trend is sitting down there at the 0 to 2 microvolt baseline. So that indicates a flat EEG, but there's projections upward that indicate the bursts. So we can tell that this is a relatively flat EEG with bursts. I didn't have the other side, but the other side is the same. This is another burst suppression EEG, and what you see here, where I've got my orange cursor, is that we have gaps underneath the amplitude integrated EEG, and this indicates that this is an area that's likely to be a seizure. And you can see that it's lateralized. Again, we're doing left, right, and then a transverse montage. And we're actually seeing this primarily on the right side. And you can correlate the EEG below it. I'm sorry, this is a European montage, so it's right over left. And you can see that the particular seizure that we're looking at is actually occurring in the left hemisphere, not so much in the right, although a lot of the other ones that you see later in the record, some of them are lateralized, some of them are not. So again, this is burst suppression with a seizure, with several seizures as well. Another example of a status epilepticus, and again, the things that you can adjust in the amplitude integrated EEG, the electrodes that you include can be adjusted, whether you're bipolar or referential. Typically, these are always bipolar. The color of the trend, not a whole lot that we can change here with the amplitude integrated EEG. Even the bandpass is really defined by the trend type itself. So a few things that you can change in the amplitude integrated EEG. And this is amplitude integrated EEG and status, both with the Cadwell and with the Persist software. And you'll see they look very similar. On the top, I've got the left side, and I only have the left there. With the Persist software, you can superimpose left and right, and you can see if there's any variability from the left and the right side, and it's in this case is pretty minor. Persist also has the burst suppression ratio, or the suppression ratio, which you see down at the bottom, and that is about a 30-minute time period, and you can see that we can see the burst suppression as it becomes less suppressed as we go on. So I can't actually see where my cursor is here, but I'm going to guess it's earlier in the record where it's more suppressed and the bursts are of higher amplitude. I'll have another example later on that we can look at there. So in summary, amplitude-based trends provide information regarding the amplitude. They do not provide frequency information, and these include the envelope asymmetry, amplitude integrated EEG, and the suppression ratio. So our next quiz, Lori, if you want to launch the next poll, the envelope trend gives you information about the EEGs. A, frequency, B, phase, C, morphology, or D, amplitude. So by definition, the envelope trend is an amplitude-based trend, does not give us any information with regard to frequency, with regard to phase, with regard to morphology, only gives us information with regard to amplitude. So Laura, if you can close that poll. If you look at the envelope trend, here again, the status epilepticus patient, you really see on the left-hand side, you see microvolts. Again, your x-axis is time, y-axis is voltage, and so you're really just getting information here about about voltage. Next question. Laura, if you can launch this one. The y-axis in amplitude integrated EEG is typically expressed in units of. So this is amplitude integrated EEG. Our choices are frequency, ratio, percentage, and amplitude. And it's in the name. So hopefully everybody will get this correct. Amplitude integrated EEG is expressed in units of, actually, really the units should be microvolts, but that is a measure of amplitude. So shame on me for a bad question, but it should be microvolts or amplitude. Okay, Laura, if you can close that. All right, so you see on the left-hand side, again, your semi-logarithmic scale from 0 to 100, showing the amplitude. Okay, so let's talk about frequency-based trends. And all of these are based on the fast Fourier transform that, like a prism splits white light into its different wavelength, FFT splits a polymorphic waveform into its different frequencies. And so we use the FFTs to identify the frequencies that go into the band power, the power ratio, which is also the alpha delta ratio, spectral entropy. All of the spectrograms utilize the results of the fast Fourier transform. So the first one, the band power, you can see the calculation below, but really all this is telling us is that we are going to specify a band of power on which to do the calculations. So we're going to rely on the FFT to just extract one particular frequency range. So determined by you, you can set it to whatever you want. And we are just going to examine the power for that frequency. So again, here's a normal EEG, and we're looking at a graph of the alpha activity over a period of time. Actually not sure how long that is, but I'm going to guess it's about half an hour to an hour. And so you can see, again, what can we see by looking at this? Well, we're measuring the scale in amplitude. We are looking at a specific frequency, so we can see the frequency information. We've got symmetry. This is the left side over the right side. So we could tell that it's this normal study is very symmetric. And with regard to variability, it's variable without appearing to be periodic in any great way. If we add all the other trends and look at all the different frequency ranges, you can see that early in the record, there's a lot of activity, a lot of amplitude in the lower frequency ranges. So you can see the blue trends up there that are 1 to 4 hertz. There's more of the power in that first section, and that drops out a little bit as we go on. The 4 to 8 hertz, the theta range, pretty consistent, but that also drops out towards the end of the record. And towards the end of the record, if you look at the green, which is the alpha, you can see that alpha picks up. So this is telling us a story about this record over time, and it's telling us that early in the record we have more slower frequencies, and later in the record the fast frequencies pick up. So I would guess, if I were to look at the R.EEG, that what we're looking at is in the early part of the record, this patient's asleep. In the later part of the record, they're awake. Band power is also useful for looking at seizure activity. So here we have the band power in the 4 to 8 hertz range. We've specified that, and what we're looking at is a variety of peaks. And if we place our cursor on one of those peaks, what we see is we, in fact, have a patient who's in status. So band power is useful if you're looking at a narrow frequency range. We could use this to identify how many episodes of 3 per second spike and wave somebody had if we were looking at a long-term record, and we wanted to utilize this for looking at 3 per second spike and wave. The things that we can adjust here, again, like any of the others, we can do inputs. Which electrodes do we want to include? We also determine what our frequency range is. In this particular event, I've decided to include all the frequencies from 1 to 30 hertz. And then we can adjust whether it's a bipolar referential montage. Power ratio, and the most common one is the alpha delta ratio. And again, we're looking at the FFT. And before, what we did was we picked one specific frequency. Well, with the power ratio, we're going to pick 2 specific frequencies. So we are going to compare the amount of alpha in the recording to the amount of delta in the recording. And again, use the FFT to do that. And here's alpha delta ratio, again, with our normal patient. And this tells us we've got a 2-hour window here. You can see that early in the record, the alpha delta ratio is extremely low. And as we get later into the record, the alpha delta ratio is extremely high. So what can you determine from this? Well, you have a measure of amplitude, but you're really looking at a frequency ratio. You can see we've got left over right, so you can see it's symmetrical. And you can see it's not really periodic, but it's variable. So variable over those 2 hours in that you see changes in the alpha delta ratio. So this is, in fact, the same normal patient that we looked at before, where in the first hour and a half of the record, the patient is asleep. So you've got mostly those slow frequencies, and later in the record, the patient is awake, and you've got that nice delta popping out where I have the cursor. I'm sorry, that nice alpha popping out where I have the cursor. So alpha is the numerator, delta is the denominator. So when the alpha pops out, of course, that alpha delta ratio is going to be higher. I have a generalized slow study here that has spike and wave in it. Pretty unremarkable. What you see is a looks relatively low amplitude ratio, so to speak. The frequency is pretty invariant, except for these episodes where we have bursts, very short bursts of spike and wave. And it is in fact symmetrical. It's symmetrically slow. We don't see a whole lot of variability except for these periodic episodes where we have the bursts of spike and wave. Similarly, if I do this with the persist alpha delta ratio, you'll see that we pretty much have the same peaks. Again, bar graph versus a line graph. Now, closely related cousin of the alpha delta ratio is the alpha variability trend. They show very much the same thing. I'd like to show this one because what you see is the yellow cursor there is on the area where we have a lot of alpha variability. So we have a high alpha ratio. And in the second window, what we see is the cursor is placed where we have very low alpha variability or low alpha ratio. And so the first case, if you look at the raw EEG, compare that to the second case, when they're side by side, it's easy to tell that the bottom one is much slower. Excuse me for that. If you imagine that this raw EEG, the change in the raw EEG occurs over a number of hours as it does, what we're looking at is changes that occurs over, probably 4 or 5 hours between the two, and that's much more difficult to see in the raw EEG. Much easier to see in a power ratio trend like this, but tougher to see in the raw EEG as it changes more slowly and more subtly. So the power ratio, the things that we can change now, I've shown you alpha delta ratio because that's the most commonly used. But if you wanted to change your frequencies for the numerator and the denominator, you can certainly go into the trend settings and change those, as well as your color, the electrodes you include, and things like that. Your time base can easily be adjusted. So if you were, for instance, more interested in the beta to theta ratio, you could create that and show that. Not seen a lot of, well, on that particular one, I haven't seen any work done on that yet, but I'm sure it exists. Spectral entropy is the next frequency-based trend, and spectral entropy I have seen mostly used for anesthesia. It is the basis or very comparable to the BIS monitor, where you get a numerical value that tells you whether the patient is awake or asleep. Again, here it is you're looking at a number of different things and getting a simple number out of that. This is an example of the spectral entropy or sample entropy being compared to the BIS monitor during anesthesia induction. And so you can see that the numbers drop out during that induction, and as you get into that burst suppression pattern, you see those numbers drop out. Here's a burst suppression EEG, and you can see those numbers, the values do drop considerably with the burst suppression. The things that we can adjust here, typically if people are going to use the spectral entropy, they may want to set some sort of an alert that tells them that the spectral entropy value is above or below a value, and notify us if this is below or above a specific value. So you're allowed to set the values here. Otherwise, the main things you change are which electrodes you include, the stop and start frequencies, and things like that. Spectrogram. And spectrogram is probably the most often used of all of the frequency-based trends. With spectrogram, we're looking at again, an x-axis of time, y-axis of frequency, z-axis of color, which is color, but it's a z-axis of power. So when you're looking at blue, there's not much activity or not much power. When you're looking at red, there's a lot of power. Now, this is a normal study, and if you look at this over what I'm going to guess is maybe a half an hour, I've got my cursor set on that frequency. Again, so our scale is 0 to 30 hertz. So that cursor is placed on that area where you have a lot of activity in the alpha range. So this is a person who is awake where my cursor is. You can see the raw EEG on the left. And earlier in the record, you can see there isn't a lot of alpha because that patient was asleep. Now, I'll talk about this one a little bit more when we talk about artifacts, but that's a quick overview of the artifacts. You can see this kind of single color peak is pretty typical of an artifact in spectrogram. So you will quickly learn what to pay attention to and what to ignore. The other thing that we're going to see in this is there are these little technical term I use is blips that are occurring at about 14 hertz, and these are the sleep spindles. So this is a nice little representation of a very brief event that we can actually see in the spectrogram, and that's just those little 14 hertz bursts. We could also use the spectrogram to identify seizure activities, as you see in this seizure patient. We can adjust the frequency range. We can, again, determine what our inputs are and adjust our time axis, all within the analyzer settings. This is the another example of the status epilepticus patient using the FFT spectrogram. So you can see again the scale, and this is up at the top on the right of the trend. You can see the scale. You can see the range 0 to 20 hertz, and it shows these bursts of seizure activity quite well. There's the rhythmicity trend. Here's a normal one. And again, this is the same patient. So you can see that the dark areas on the trend on the right are the alpha range, which is where our cursor is. And you can see that when we have a rhythmicity spectrogram with seizure activity, it presents a much different appearance where you can see kind of the progression across the different frequencies. The asymmetry spectrogram, this study that we have in particular, not particularly asymmetric, although you do see quite a bit more blue, suggesting that it is more left-sided. And in fact, even though the abnormalities are across all sides, it may be higher amplitude on the left. I'm sorry, on the right. So if we do have a asymmetry, we can use the asymmetry spectrogram to identify that asymmetry as well. And again, this is showing us that the asymmetry is much more prevalent on the right side, as indicated by the red color. So frequency-derived trends use the output of the Fourier frequency analysis or the fast Fourier trend to show us either a 2D image or a 3D graph. The 3D is spectrogram showing power ratio or percentages, and these include the band power, power ratio, spectral entropy spectrogram, rhythmicity spectrogram, and the relative asymmetry spectrogram. So we're going to do a quiz. Lori, if you could pull up the next quiz. This is the frequency-derived trends. The y-axis, so remember the y-axis is going up and down. Y-axis is typically, in spectrogram, is typically expressed as A, amplitude, B, ratio, C, frequency, or D, a percentage. And you'll remember the spectrogram is the only one of the trends that has both an x-axis, a y-axis, and a z-axis. And our x-axis is always going to be time with the spectrogram. So Laura, if you can close the poll, with the spectrogram, our y-axis is going to be frequency. And finally, the z-axis in spectrogram, I mentioned spectrogram is the only one that's a 3D trend, so to speak. The z-axis of the spectrogram is typically expressed as, Lori, please go to the next poll. The z-axis is typically expressed as A, amplitude, B, power, C, frequency, or D, percentage. So we talked about the x-axis being time, the y-axis being frequency. So the z-axis, the scale that we see over on the left, is power. So microvolts squared, it represents power. So the correct answer, power. And please close the poll. Okay, so I'm going to run through some of the trend panels before we get to modifying the trends and looking a little bit more at some of the artifacts. Quick definition: the trend panels are all of or several trends configured on one screen. And as we talk about what you look at, what you look for as you're identifying different things in the trends and trying to root out whether something is artifact or not, keep in mind that last point, using the trend panels helps you to cross-utilize the trend. So really one trend can lead you astray. Multiple trends will help you zero in on what's going on. Very much the same as looking at one montage all the time can give you a false sense of security. So if you use different EEG montages, you can see the benefits of a bipolar montage, the benefits of a IPSI-EAR reference, the benefits of a CZ reference. Trend panels are very much the same way. You look at multiple trends so that you get the advantages of each one. Now, one of the Cadwell trend panels that we have is a universal default. This one gives us a quick overview of what's going on. This may be the first one that I'll pull up just to kind of get a quick overview of what's going on in a recording. This is going to give me all the information with regard to amplitude, frequency, the periodicity and variability, but it doesn't give me symmetry because I've included all of the electrodes in each of these trends. So I've got the amplitude integrated EEG trend, the band power trend, the envelope asymmetry, the envelope power ratio, spectral entropy, and spectrogram. And for a case like this, where you can see this is actually the status epilepticus patient, it identifies that there is something going on throughout this study and that it's very periodic and that there's a couple of events where it's a little bit different, but it gives us a very good overview of what's going on. And it doesn't tell us whether it's lateralized or not. So for that, we would want to go to a different trend panel. And this is using the same universal trend panel, panel A, using this for as you can see on the left-hand side, a burst suppression patient. And what you see in this one is not so much the periodic nature of the recording, but you get an assessment. And remember, when we talked about the amplitude integrated EEG, and we talked about how we identified burst suppression by the flattening of the record. So how the base of the trend is down at the zero baseline. So this tells us it's a pretty flat record. Early in the record, our cursor is actually placed out there later in the record. So the EEG that you see to the left has less flattening than what we saw earlier in the record. It also has lower amplitude bursts. So what we see in this trend, again, amplitude integrated EEG is strictly amplitude. So we see kind of a tightening of the amplitude, even though we're still seeing largely a burst suppression. It's not as flat as it is earlier in the record, and it's not as high amplitude with the bursts either. So we can see that pretty readily in the amplitude integrated EEG. In the band power, we can see a diminution of the power in the range that we selected there. In the envelope asymmetry, we can see that it's pretty symmetrical. Envelope trend beneath that is telling us that there's a significant decrease in the power in the envelope trend as we move forward, and that's likely due to the lower amplitude bursts. Power ratio is telling us as well, again, this is that the amplitude of that activity in the alpha range has decreased significantly compared to the power in the delta range. So earlier we have a higher alpha percentage, later we have a lower alpha percentage. And the spectral entropy is telling us that we have a lower spectral entropy later in the record. So earlier in the record, the spectral entropy is higher, increased variability, increased randomness, so to speak, or increased ability to do power early in the record, and later in the record it is less so. And then the spectrogram also, the bottom example, gives us a indication that in fact not just the alpha power is high, but early in the record the power across all the frequencies are pretty high, and later in the record it is primarily in the slow frequency ranges. Panel B is one that I use frequently for identifying seizure activity or rhythmic activity. And in this case, we're looking at a 2-hour time base. And we see the the amplitude integrated EEG trends up top, envelope trend below that, left and right spectrogram below that, and the envelope asymmetry trend. So what I'm gathering from looking at this trend is one that we have a abnormality or some activity that is very periodic. It is very symmetrical, and we're seeing it across all of the trends. And so that is actually another example of the status epilepticus. There's another trend that used if I'm looking for something that occurs more slowly over time, and this primarily is the alpha delta ratio, and we're seeing burst suppression on an 8-hour time base. And you can see there's areas where the alpha delta ratio is higher and lower. It is somewhat periodic, and that may be due to a medication effect, but you can see that early in the record, more alpha, later in the record, that alpha drops out, and we have incrementally more delta power. And from the envelope asymmetry at the bottom, you can see again it's pretty symmetrical, and the spectral entropy really just kind of trends along with the alpha delta ratio. So that's panel C. And then the persist trends, we have the comprehensive panel. And what can we tell from this? Again, we don't have the raw EEG here, but what we can see from the rhythmicity spectrogram is that there's rhythmic activity occurring there at about 420 and about 440 or 430. Let's make that 437. There's an increase in the power in the higher ranges in the FFT spectrogram, and a change in the relative asymmetry spectrogram that sort of favors the right side a little bit, although not a great deal. And then in the amplitude integrated EEG, you can see a nice symmetrical peak between the left and the right. Nothing registering there in the suppression ratio. So what you can see is a couple of events that I would examine further as likely seizure type events. But again, as with any of these, you want to look at the raw EEG to verify what you're seeing. Similarly with the comprehensive trend, this is the comprehensive panel as well. This is a slightly different patient, and what you see is difficult to discern any kind of real periodicity in the spectrograms, but if you look at the bottom trend, the burst suppression ratio, what you see is, you know, a high burst suppression ratio early in the record and lower as you get out towards the end. This is actually a 30-minute period of the burst suppression. And because it's just consistent bursts throughout, you actually can see it a little bit in the spectrograms, but it's a bit tougher to see it in the spectrograms. It is there, just tougher to see. Peak envelope panel. I'll touch base on this real quick, what we're seeing here. And you can see it more so in the rhythmicity spectrogram. This is a 30-minute recording, and you can see that those peaks in the peak envelope correspond with the ones that we see in the rhythmicity spectrogram. Now, normally what I would do is hide the ones down below the spike detections, but in this case you can see those, and it's pretty evident that these are identifying rhythmic activity for us. And if we look at the raw EEG, we would see seizure activity. So another question, Laura, if you could pull up the poll. Why use the trend panels? So why not look at each of the trends individually? The majority of the time, what I've shown you is the trend panels. So, or I'm sorry, is the individual trends to kind of drill down a little bit on what's important about each one. So why put them all together? And our responses here is A, the trend panels provide more complete information. The B, trend panels may resolve ambiguities between the trends. C, all of the above, or D, none of the above. And in reality, we could also add in here, the cross utilization of trends. That's what B refers to. The correct answer is C, all of the above. Laura, if you could close the poll. Like I mentioned with using different montages, a CZ reference, an IPSI-EAR reference, a bipolar montage, a transverse montage. We use all these things to compare one to another to see, do our suspicions hold up about what we're seeing, and to help us resolve any kind of ambiguities between the things. So really it provides more complete information and helps us identify and root out ambiguities. Now, the question came up last week about dealing with artifact, and I wanted to kind of flesh that out a little bit because what we see a lot of times, I'm going to grab something and move that out of the way a little bit. So if we look at something that's got a lot of artifact in it, and we look at the trend, if you look at that trend, we've got an earlier peak. My cursor is on this peak that shows a lot of muscle activity in the in the raw EEG. And I don't see a tremendous amount of anything significant in the envelope trends below it, left and right, even in the left and right spectrogram. Nothing outstanding. But if there's artifact going on, what we want to do is identify the artifact, compare it to an abnormality. If you see an abnormality, a lot of times what you could do is identify how they compare. And this is what I was talking about last week when I said that you will learn kind of what things look like across patients, but you'll also learn what things look like within a patient. So certain things that may look abnormal in one patient may be exactly what you expect to see in another patient. So you get a feel for that, and it's hard to enumerate what all those things are. But adjust your inputs if you need to. Adjust the filters if you wish to. You can cross-utilize other trends to resolve the questions that you have. But the number one thing is to rely on the raw EEG. Rely on the raw EEG to identify whether something is artifact or not. That's really the key when you're dealing with artifact, because some things are just you'll just get a feel for them. So let me pull up this other example. This is actually the same record. And so I've placed my cursor a little bit later in the record, and you can see the abnormality is clearly still there. But what we're seeing is this big peak that in the amplitude integrated EEG that's kind of drawing us to the abnormality because there's a lot of muscle activity. So you're picking up an increase in the amplitude, whereas not so much when you're out here in the clean record. So I would collect that as a registration point if I'm looking for abnormality. In this record, we're going to see it likely all the way throughout the whole thing, but I would register that in my brain that in this particular record, that peak or that gap in the amplitude integrated EEG does not necessarily conflate with an abnormality, but it's likely to conflate with a artifact. Here's another one. So I showed you this patient earlier when we were talking about the spectrogram, and you can see my cursor is actually placed on that red mark, and you can see it's pretty much red, pretty universally red throughout the whole frequency range. And that's something that you'll recognize pretty quickly as an artifact. If it just kind of obliterates the whole frequency range with with high amplitude color, that's pretty indicative that that's an artifact. And in fact, this is a normal patient, so you can see that all of those things that cross across the whole frequency spectrum are artifacts. So again, this is the one where I showed you the little blips that show the sleep spindles and the activity that shows the increase in alpha power later in the record. Now, this is a different record. This is an abnormal record, and I just wanted to use this one to show you a little bit of what we're seeing here. So if you look at this record, you'll see where my cursor is placed, but you'll also notice that several of the other peaks that we're seeing in this spectrogram have sort of this banded appearance, where you can see it's kind of striped as the peak projects up. So you have power in different frequency ranges being affected when the patient has their episode. And this is something that's pretty good to go by if you're trying to differentiate real activity from artifact in the spectrogram. This is something that I've always found somewhat useful, not in all cases, but in particular cases, this striped pattern helps me to differentiate. You can see that there's even at the same area, there's kind of that cloud of yellow up in the beta ranges, and that's all that muscle activity. But you can see the clear difference in the peak that we're looking at that has that striped and banded appearance. Let's see here. Thought I had another example showing just the artifact, but anyway. So what are our other options if we look at this? Artifact rejection is one of the options. You have artifact rejection on the Persist software, and you can see right now I've got my cursor on the peak indicating that seizure, and you can see the seizure in the raw EEG. Now, in the spectrogram, the FFT spectrogram, you can see there's some black area there, and that's suggesting that there's artifact in those areas. And so we're not going to process the trends for those areas. And you can see in the rhythmicity spectrogram, there's kind of blank areas in there, and below in the asymmetry spectrogram, there's blank areas there as well. So that's telling us that when the artifact rejection or artifact reduction is on, it's not going to process those areas because it's identified those as artifacts. So let's look at what's in those when I've moved my cursor, and you can see that yes, in fact, there is artifact in those, and that's why it's not processing those segments. Now, if we turn off the artifact reduction, you can see that at those particular events, there really isn't a lot showing up in the trends either. So this is a tool to kind of identify those artifacts, and but yeah, in some cases you'll find that it interferes with the trends. In some cases it doesn't. So you can try that artifact reduction and see if it makes a difference as well. And in the Persist, the artifact reduction is just an icon at the top of the screen that says AR. And if it's on, you may see some of these little black segments in the spectrogram or some blank areas in the other spectrograms. So that's one way, but it's important again to identify the artifacts, compare the artifact to if you have an abnormality, you can differentiate between the artifact and the abnormality pretty readily at the beginning, and then if you have a 24-hour study and you can see that abnormality pretty quick, you can differentiate through the rest of the record fairly easily. And again, that comes with practice within patients and across patients. But if you can't get rid of an artifact, or you can't readily identify the artifact from the abnormality, you can adjust your inputs. Drop out an electrode that's confounding your trends. You can adjust the filters, narrow your filters to remove a particular artifact if it's particularly high frequency or a particularly low frequency, and you can cross utilize other trends to resolve the questions that you have. And by all means, rely on the raw EEG. I have to apologize. I have been on a tear here and forgot to stop for questions. Are there questions? Okay. No questions.
There are no questions.
Okay. Thank you, Anita. So that's kind of the overview of artifacts.
Oh, now one just showed up. A question just showed up.
Okay.
If trend panels are already useful to see sudden changes in the EEG, then why go through the trouble of identifying artifacts?
So that's a good question. Really, you're only going to identify artifacts if you're unsure of what you're seeing in the trend panels. Trend panels are one tool. Just like the trends themselves are simply a tool, there's no tool that will work for everything. So in the trend panels, you can identify things that go on based on their different characteristics, but to really identify exactly what it is, you go back to the raw EEG. Then you get that morphology information, you get that phase information, all of which kind of completes the picture of what's really going on. The trends are kind of giving that big picture overview. Does that answer the question? Any other questions? Okay, so the trend parameters that,
Marco?
yes.
The question is, the reason is because you will need to take a closer look at the EEG anyways.
Right. Oh, absolutely. Yeah, if I don't emphasize this often enough, really the only thing that matters is the raw EEG. So the trends by themselves do not identify what's going on. It's that clinical expertise that you as the expert show in pulling this all together. So trends are just one aspect of this. All right. So if we look at different trend parameters, I'm just going to identify rather quickly how and why we might want to adjust some of our trend parameters. Most of them have pretty good defaults out of the box, but from time to time we may find something that's a little bit different that we are dealing with a patient whose abnormalities we want to bring out a little bit better. So the things we'll look at are the time base, the y-axis, the time base or the x-axis, the y-axis, epoch length, epoch averaging, and the electrode inputs. Okay, so we'll start with this time base. So if we have a time base, this is a 16-hour time base. So it's got a lot of information in there. What I would tend to like to do, and in this particular case, these seizures, I said the seizure word, which I know from looking at the raw EEG already, but these events are pretty tightly packed together, but they're not completely bleeding into each other. You'll find that there will be some where they're one right on top of the other, and you really just, like you would do with the EEG, you want to spread things out a little bit to be able to see them a little bit better. So you're going to adjust your time base, and in this case, what we're going to do is we're going to adjust our time base to 2 hours. That spreads things out so that we can more clearly see each of these events. Now, if we had a patient who had 2 or 3 seizures during this 16-hour period, that would be very easy to pop out and identify. This one, because they're all squished together, is a little bit more difficult to see. So adjusting your time base to 2 hours, there's a little drop down in the Persist software. In the Cadwell software, it's at the lower right-hand corner. You can select the number of minutes or hours that you're looking at on the screen. So time base is really helpful for adjusting to be able to differentiate what's going on across the time the x-axis. Adjusting the y-axis depends on exactly which trends you're using, but generally speaking, as you see with the envelope trend here, the y-axis can be adjusted by grabbing that little slider on the left-hand side of the screen and dragging it up or down. In the persist trends, you can right-click in the middle of the screen, go to the trend properties, and adjust that y-axis there. And in the spectrogram, which I mentioned is the only one that's a 3D trend, because you have an x-axis, a y-axis, and a z-axis. That slider bar actually applies to the z-axis. So in order to adjust the y-axis, we're going to go to our settings on that little cogwheel on the right-hand side of the trend. We're going to open that up, and we're going to adjust our frequency range there. That's the only one that's really tremendously different. And as I mentioned, if we want to change the z-axis in the spectrogram, for spectrogram only, we're going to use the little slider bar on the left-hand side. If we're going to change it in persist, we're going to click on that scale, that little scale that you see the little yellow arrow, and it's going to pop up our z-axis range. Okay, another quiz for us. This record may be described as, and you can see the example of the record. Its polls are open. So first of all, I will say, we have some qualitative descriptions here. So seizures, well, gee, without the raw EEG, we cannot tell whether these are seizures or not. Again, that's something that comes with the clinical expertise, and we need to see the raw EEG to identify whether they're seizures or not. We really can't tell whether these are lateralized or not because we don't have left and right information on this particular trend. We can't tell if they're monomorphic because none of these trends identify the morphology of the waveforms. So the only thing that we can answer correctly here, and Laura, if you can close the poll, the only thing that we can answer for sure here is that this activity is decreasing in power. You can see that it's decreasing in amplitude in the amplitude integrated EEG trend and in the envelope trend, but you could particularly see in the power ratio trend and in the spectrogram the decreases in power. So the answer for this one is B, the decreasing in power. And there's the raw EEG. This is in fact the burst suppression pattern that we saw before, and this has much more flattening and bursts early in the record. Now, to gain a better appreciation of the trend in the example below, what would you do? Laura, if you can start this poll. You have an envelope trend. This is the left side. If you want to better see what's going on, would you adjust the epic averages? Would you adjust the z-axis? Would you adjust the time base? Or would you adjust the y-axis? Well, the reasons for adjusting the y-axis are really to be able to bring everything within range so that you can fit the top and the bottom of the trend on the screen. And so we don't need to adjust the y-axis. The z-axis, because this is an envelope trend, we don't have a z-axis. And the epic averages, we actually looked at this study a little bit earlier and didn't see a lot of difference in the epic averages. So the correct answer, and if you could close the poll, the correct answer is C. We would adjust the time base. We want to spread that time base out so that we can identify each of the individual each of the individual peaks, and so that we could zero in on the seizures themselves. And then final question here, to gain a better appreciation of the trend in the example below, would you adjust the epic averages, adjust the z-axis, adjust the time base, adjust the y-axis? How would you bring this out a little bit better? Now, I actually don't know the time base here. We've already looked at this. We know that we're not going to adjust the epic averages. We know that we do not have a z-axis, so B is not correct. We could adjust the time base, but the thing that I would go with here is adjusting the y-axis, because as I mentioned before, with the y-axis, you're going to adjust that so that you can see the top and the bottom of the trends, so you can see what's hiding outside of the amplitude range that you're looking at. So the correct answer here is adjust the y-axis. Okay, so quick summary of what we've gone over. We reviewed some of the basics that we went over last week. We dug a little bit deeper into the trend settings, how those trends are set up. We looked at the different trend panels and looked at some clinical examples with those. And then we spent some time modifying the trends, making adjustments to the trends, and talking about how we deal with artifacts. So, having said that, are there questions?
Marco, there's another question.
Yes.
In addition to the AEG, are there other different trends that are applicable to the NICU? I guess it means neonatal ICU.
Well, that's a good question, and the honest answer to that is I don't know. So there are trends that I like to use for neonatal ICU patients, but I don't know of any of these the frequency-based trends that are in regular use. So the amplitude integrated EEG is the one that's most commonly used, and it's one for which there's the greatest body of literature. But I would certainly utilize some of the other ones just to see what you can identify. And remember, I've also left out of this entire presentation any discussion of seizure detection or spike detection. And there certainly are as well other tools for neonatal seizure detection. But at this point, I just haven't seen a lot of these other trends used with neonates. So if there is anybody out there that is currently using different trends for neonates, I'd very much be interested in hearing about it. So yeah, please let me know. Type it into the chat if it's something that you're currently doing.
Another question, Marco?
Yes.
What trends would you use in the pediatric EEG for artifact identification?
Well, if you look at most of these trends, spectrogram is one that used very regularly. And I really do like the spectrogram as kind of an overall go-to trend. You can see that it does incorporate artifacts into it. But a lot of times you can identify, you can differentiate the abnormalities versus the artifacts. So that would probably be my go-to, would be the spectrogram. But I wouldn't ever stay with just one. So something like um, the spectrogram with the amplitude integrated EEG, with the envelope trend, um, perhaps with another frequency-based trend. I would create a panel that included all of those. And if you look at some of the panels that we have currently, the comprehensive panel in PERSIST is a good example of using numerous trends to kind of compare one to the other. I don't know, or the trend panel B in the Cadwell software that uses that is good for detections. Either of those are pretty good panels to use to incorporate all the different kinds of trends. I don't know that there would be necessarily a lot of applicability with something like spectral entropy, but I certainly wouldn't rule it out. And any of these depend on what you're looking for. So whether you're looking for, if you're looking from the perspective of a child who's bouncing around, all of the trends are going to be affected by that. If you're looking for a child in the pediatric ICU, then the fact that they're pediatric probably doesn't make a difference in the trends that you choose. I hope that answered the question. Other questions?
I don't see any more questions.
All right. Thank you, Anita. Thank you, Lori. Thank you all for coming, and I hope you got some good snippets out of this presentation. I always find that I pick up a few little nuggets from the presentations that I attend, and I hope you got some good information out of this. By all means, if you have questions, my email is posted here, and if I can help you with any other questions, I'm more than happy to do so. So thank you very much.
Thank you all for attending, and the recording of this session will be sent by email within the next day or two. Thanks. And we have another session with Anita hosting next Wednesday, August 19th at the same time. You can go to cadwell.com to register. Thank you. Have a great day.
Thank you.
Thank you.